Caprio. Everyone in Red Group has seen my name very often, so now you know what I look like. I'm doing my report on CAUTI, which is catheter-associated urinary tract infections, especially in my ICU, where more recently we've had some come back against us. Prior to that, we were 365 days without a CAUTI, so it's kind of been shocking for us. So I wanted to know what was going on differently in our unit than in other units that was causing us to have more CAUTI occurrences than elsewhere. I find that many of the nurses in the ICU may put in Foley catheters without orders. They're easily accessible. Physicians sometimes, especially night shift, are harder to get a hold of, especially if they're not hospitalist patients. So, and even if you call them, they're more than likely not going to put in orders for you. Even with physicians being online now and everything is all electronic orders, minus the few that still give written orders, of course. But I feel that it's the duty of physicians to be able to put the orders in, even if they're called at 1 in the morning, they have access from their home computers, and that nurses shouldn't have such easy access to be putting in their own orders and doing things without first notifying the physician. When you think about it, CAUTI is super important because it's considered a hospital-acquired infection, and all hospital-acquired infections are important because they cost the hospital lots of money if it's acquired in the hospital, usually at the fault of physicians or nurses or aides or anyone involved in the patient's care. The annual cost for a CAUTI per facility, it varies and is $1,000 to $3,000 for additional care, including antibiotics, antimicrobials, anything, especially if it turns into bacteremia, which can be serious and expensive for the patients. In addition to getting a urinary tract infection, patients may experience longer stays in hospital, extended care, further care when they're discharged even. Overall, it's a big deal, and there's a lot of money that goes into preventing CAUTI and paying for CAUTI. So I thought this was a good thing to do, especially in our hospital experiencing more recent occurrences of CAUTIs. My project aim is to reduce the number of occurrences of urinary catheter-associated infections in my facility by 10% within 6 months of new system barriers implemented. The prevalence of catheter use among hospital patients ranges from 67 to 76% in critically ill patients, which is the majority of patients we see in the ICU. And 1/3 of those may not have appropriate indication for catheters to be used. I think that says a lot for our unit. I think that's the common problem in our unit is nurses will insert catheters for convenience, or they think it is necessary when it's not always necessary. So I think this is an important aim. I think the most important goal for this project was that Foley catheter ordering can only be done by attending physicians or hospitalists, and that nurses will no longer be able to go into the computer system and order Foley catheters under written or telephone orders via the physician like they normally do without actually getting verbal or written orders prior to insertion. I think this will prevent a lot of unnecessary catheterizations because nurses will be restricted to actually making these phone calls in the middle of the night prior to inserting Foleys at their own discretion.